Good morning, everyone, and thank you for joining the CQC team for this webinar on adapting care delivery to the new normal. We're delighted you're all here to join us today. As a reminder, this session is being recorded and will be available to you after the webinar is complete 2 to 3 days after today. Before we get started, I would like to review a few Zoom tips. We will have a couple polls during today's session to participate. Please select your answer and make sure to click the submit button to make sure that your answer is recorded. If you would like to speak during the Q&A section, you can mute through your computer's controls and through the phone by pressing *6. If you have any questions or comments, please utilize the chat box and we'll moderate and answer as best as we can. We are now sharing a PDF of the slide so you can follow along if you like. We have included a picture right here. You just have to click this download button and you can select the location where you would like to download the slides. If you have any technical issues, please direct your message to me, Jose Ordóñez, and I will do my best to assist you. At this time, can I please ask everyone to chat your name and organization that you're part of. Welcome everyone. As we get more people doing that, we'll slowly transition to the next slide. So at this moment, let's start by our first poll of the webinar and hear about where are you joining from and the type of organization that you're joining from. So I'm gonna launch a poll. And please select your answer and make sure to hit that submit button. And I see that there's representation, from the Bay Area and of course Los Angeles area, and we have also someone from outside from California, so that's great. Thank you for joining. In organizations today, we have providers, a lot of people from IPA and the nonprofit as well too, and other organizations as well too. I'm gonna give you a couple more seconds, and please make sure to submit your answer. I'm gonna share the results. Okay, mostly of the Los Angeles area. And definitely a tie between other organizations, IPA, and nonprofits. Okay, and at this moment, I would like to transition to Christina Moody.
Thanks so much, Jose, and really pleased for all of you for joining us today. I'm glad that we're going to have a mix of different types of organizations as we're hoping to have a really interactive session as we talk about providing care in this new era. So my name is Christina Modi. I'm Senior Manager of Improving Advising here at the California Quality Collaborative, or CQC. CQC supports quality improvement in the healthcare delivery system across California. During the public health emergency, we've been hosting regular webinars for small practices and IPAs, providing peers and experts opportunities to share lessons learned and successful practices as everyone's adapting to providing care virtually, and as we'll talk about it today, in person when needed. While we aren't planning additional webinars at this time in our COVID series, we're always open to hosting future sessions, so please reach out to us if there's a topic that your organization would find useful. After the webinar, we encourage you to access our CQC COVID-19 resource page, which includes some external resources as well as the full webinar series. CQC also provides support on other delivery system transformation efforts like behavioral health integration. We are very excited to launch a new webinar series next week on accelerating integrated care. Our first webinar is focused on aligning payment for integrated care and will be next Wednesday from 11 to 12. And the registration link is in the chat right now. We hope to see you there. Next slide, please. Additionally, CQC has been planning our next practice transformation learning collaborative called CalHive. Given all the changes to care delivery over the past few months and expected in the future as well, we're collecting feedback to make sure that we're offering programming that meets participants' most pressing needs. So we'd love to hear your on-the-ground experience that you can provide by completing our quick survey, 10 minutes or less. Michael will put the link in the chat. Thank you very much if you're able to complete that survey. Next slide, please. So setting the context for today's topic, data has shown that compared to late March, primary care practices of all sizes all over the country have been steadily increasing their number of in-person visits after a sharp decline. This trend, which the slide shows with data up to mid-May based on a poll conducted by the Commonwealth Fund, will only continue as California and other states continue to open up. Each region is looking slightly different as caseloads evolve. You are all working with your public health officials locally and following their guidance to make sure that you're staying as safe as possible while also meeting the needs of your patients. So as practices are grappling with these changes, we wanted to highlight a few resources that we found useful from the American Medical Association and others that are on this slide, but please feel free to share additional resources in the chat that your organizations have been finding useful as well. Next slide. So I've had the privilege of hearing some of our provider organizations, partners, recently share what they have been experiencing since late March. In their words, in the late March period, there was a huge level of challenge, but also a level of simplicity. Follow the public health directive and move everything you could virtual. It was difficult, but also straightforward. How do you get the right technology and connect patients and providers? Today, providing care is much more complex. How do you prioritize in-person and virtual care and still keep your physical location as safe as possible? Today, we're really excited to spotlight one provider's experience, and then we're going to open it up and facilitate a peer sharing conversation to highlight your shared issues and hopefully some solutions. Next slide. So as we launch, we wanted to do a brief poll. This poll, which Jose, if you wouldn't mind opening up, is a list of challenges that was compiled from some of the registration questions that you also answered as you registered for this webinar. Please take a look at the responses and let us know what are the top 2 challenges that your organization is currently facing as you reopen. So we have getting patients needed preventive care, triaging in-person and virtual care, safety procedures, reimbursement, planning for future waves, staff or provider retention. And if there's another answer that's not on this poll, please feel free to chat it in. So let's give a couple more seconds for folks to complete that poll, and you should be able to select 2 options. So just early results, I'm seeing a lot of votes for getting patients needed preventive care and kind of equal responses for triaging in-person, virtual care, and planning for future waves. Jose, let me know when we want to, oh, there we go. All right, so the clear winner was definitely getting patients needed care. And as I mentioned, the second consideration and challenge was planning for future waves. So thanks very much for sharing that. I think what we're going to talk about today is definitely that first element, which is making sure that patients are getting preventive care that they've deferred or that they need today. On to our next slide, please. Before we turn it over to our guest speaker, Dr. Davis, I wanted to ask everyone joining us today to take a moment, reflect, and consider and also share in the chat, given everything that has changed and is still changing in patient care, what do you hope will be the new norm? So please take a couple moments and reflect and share back in the chat what you hope the new normal will be for patient care. So one response, no barriers, either for clinicians or patients to accessing virtual care whenever they want it. Thanks, Dr. Davis. So we have 80-20, back to normal versus virtual. So a mix. Going to give everyone a few more seconds to think and maybe dream a little bit about what it could look like. Thanks, Michelle, kind of adding in-person care versus virtual. So another sort of vote for hybrid. Improved integration of behavioral health and primary care. That's a very important consideration. So Divya, I encourage you to join us on our webinar series to learn more. All right, well, thank you for spending some time thinking about that. I'd like to then, next slide, Jose, please, introduce our guest speaker, Dr. Stephen Davis. Dr. Davis is a private practice family physician. He'll be sharing for about 20 minutes right now and is open to taking questions throughout. Dr. Davis is a board-certified family practice physician in private practice in San Dimas, California for over 30 years. He is currently the Associate Medical Director of MLK Community Medical Group, helping to bring compassionate, collaborative, quality care to their patient community. He was a founding member of Physician Associate IPA, a managed care organization that is now part of Optum Healthcare Partners, where he's the Medical Director of Physician Affiliates Clinical Information Service. Dr. Davis has over 20 years of community hospital governance experience in executive and department leadership. So Dr. Davis, we'll hand it over to you.
The summary of that is I probably have ADD and have been doing too much. So to just give anybody a background, I'm a private practice physician. I have a small practice. It's myself, one other physician, and a PA. And prior to this, we have 11 employees. We are 50% managed care, mainly through Optum Healthcare Partners, and we are 50% PPO, private pay, straight Medicare. Prior to this, we were seeing 50 to 60 patients a day as a clinic, and that was with 2 clinicians there all the time, and a couple half days, there'd be 3 of us there, because I'm not there all the time doing the other things. When everything hit here, of course, we dropped from 50 to 60 a day to half a dozen a day for particular reasons, and shifting everything to virtual care. And it left me wondering, who are all those people we were seeing and why? Why were we seeing so many people? Why were they in the waiting room, right? And then as things changed, everything evolved and all the rules changed slowly from week to week and month to month. My region, I'm just gonna run through the questions describing the region. I'm in LA County in the East San Gabriel Valley, the far east portion of LA County. LA County, of course, has had the largest number of cases, the largest number of deaths. We actually in our practice had one of the earliest outpatient cases back when it was, really less than 60 or 50 in the entire county. The county has flattened the curve like everybody else. Businesses are opening up, but we've seen a recent resurgence in cases and hospitalizations one of our 3 hospital local groups had about an average census a week ago of maybe 30 inpatients for COVID, and now they're up to 65 this week. So they had to regroup to find out, are we set up? Are we ready to handle it? Some hospitals stepped in, and outpatient surgeries stepped into elective surgeries, as we all know, but there's been a back push on some of that as people ended up being readmitted with COVID after going to a SNF. And so we'll talk about that as well later. The next question was, how has your practice adopted telehealth? I'm going to rewind and say everything I'm going to tell you is kind of common sense, and we learned as we went. And I learned by listening to conferences like this, and I'd get 1 or 2 things from other people. And then, of course, we always followed the CDC and the LA County health guidelines and also updates we were given by Optum and other payers. So we adopted telehealth really early because I'd already been using Zoom on a business sense. And we were able to contact the canceled and rescheduled patients first. When the whole shutdown happened and we decided we need to cancel patients, one of the flaws at the beginning was we really weren't tracking, hey, you just called and canceled people, but who were those people and why were they going to be seen? So we had to step back and log who are we canceling and why were they going to be seen. So when we started telehealth, those were the first patients we went back to on a need basis. We have Zoom Professional, and then we started with the free version of Doxy.me, and then we have the professional version of that as well. They both have their ups and downs, and there's some technical issues for patients on both of them. That's why we have 2 different ones. We trained the staff to be the patient's IT help, meaning they had to help people when they called how to download what they needed to download or what they needed to do. And then I am set up both at office and at home. I don't know if you can see me here, but I'm sitting at home right now with a backdrop of my office. And so there were a couple of days where I stay home and just do telehealth from home. We developed a whole office workflow mirroring our current workflow. That means we kept the front office doing front office stuff and the back office doing back office stuff. When they make the appointment, we'd assess their technical ability. Can they do this and how? What do they have, a smartphone, a computer? And then we'd have them preload if they needed to preload Zoom and at least practice, go to Doxy.me and try to get them used to getting it loaded up before the visit. Then the front office would do a pre-appointment check-in. They get any updates. We have our MA run it like a visit, start the EMR, do the workflows, vitals. There's a lot of vitals you can get from home, by the way, from patients that have their own blood pressure cuff, their own, they have their scale, their own thermometer. And then the MA will reconcile the medications. And then one of the key questions, and people ask questions, is quality and health maintenance. We go through their chart at that point and find out what health maintenance they're due for. And then we set that up or mail that out. Of course, we're giving the caveat they need to do this when the facilities are accepting patients and when they feel comfortable to. And some of them, I'm telling them, I'm making the decision based on the risk. Don't do this till next fall or check back with us before you do it. A key thing on telehealth, of course, is documenting what type we did, and then and also the oral permission they gave us to do it. And then in the EMR, we pre-saved telehealth physical phrases and templates and things that were different, because you don't want to fall back and use your EMR the way you did before, because you're documenting some things perhaps you can't do on telehealth. The types of visits we started with initially were routine follow-ups and labs and prior studies review, people that had things that they needed the results on. We also saw post-discharge patients virtually, people who were coming out of the hospital and necessarily weren't in a state that we should even bring them to the office anyways. And then the urgent care needs when reasonable. And we were talking earlier, a lot of people have questions, well, which things can you do on telehealth? And one of the things I did is I looked at other websites like our friends at Sutter Health, Kaiser, and other things where on their website, they say, hey, here's telehealth and here's the type of urgent care visits we do. So you can kind of get a feel of what's acceptable in the area on URIs and UTIs and other visits. Then we were very lucky, Optum and other carriers allowed us to do senior HCC assessments and reconnect on wellness updates on seniors, as long as it included video, and paid us. So we were able to connect with the seniors, let them know we're there. They really liked it. being able to talk to me. And we would just walk through and update their HCC coding, which was a benefit to us. And then we did a lot of screening visits or in-office visit workups, meaning I did a televisit and we gleaned what we needed to have them do before an in-office visit. And when would that office be? Would it be in 3 months, 6 months, or did it need it to be in next week? The next question was, what care services are you open for in person and which are still virtual? At this point, be honestly, we're just wide open. We're fully open, but we screen all patients for individual inappropriate or high-risk visits. And I use the word bi-directionally. And that means that we want to make sure they're not a risk coming into us. They shouldn't be there, and that we're not risking them by having them come out. So when I say we're fully open, we're open with the bouncer at the door and the guard at the gate, sort of a situation. But we screen all patients for individual issues. Patients really tend to self-regulate themselves. I live in South Orange County, which was the rebel rousers that kind of gave up on this whole thing a month ago. We just have wide open restaurants. But the truth is, people regulate themselves. Half the people will not step into a restaurant, and they'll decide when they will. And patients are kind of the same way. And we push the telehealth to give them an offer. Whenever we make any appointment, there's a certain set of appointments that the appointment maker has a right to say, hey, do you want to do this with telehealth? And any telehealth decisions, like on screening, et cetera, it goes to one of the clinicians as a triage. Is it okay we set them up on this on telehealth, or do we need to make it in person? In my practice, just to let you know, and I was telling them that telehealth was a big thing we did, and I'm big on technology, so I was really happy to do it. But it's been really dropped off. I'm surprised. I thought I would be much more now than I am, just because in my particular area, people wanted to come in, need to come in. And the telehealth thing isn't a huge portion of what we do, but it is a very, very necessary daily thing we do. The next question is there pre-screening before in person, and was it doing on site? We screen them at the appointment. We screen them at the front desk when they come in and they get their temperature. We have signs at the door with the questions. We screen them again when they're in the room, right? Believe it or not, Monday, a lady came in with her recurrent allergy sinus issues. She got through the appointment, she got through the front, she got through the MA. When the doctor walked in, she said, I've had a cough 3 days. I've been working in the same room with my boss, he tested positive. And it's like, now we got her sitting in the office, you know, having come through 2 or 3 people. So it was like, you can do your best. That's all I can say. So your procedures in the office need to really be set up that you're assuming everybody's an asymptomatic carrier, and you're going to work it out that way. But you're going to do your best on that screening. The other thing is, we don't allow any suspect patient to enter the office. They're either evaluated in a separate room, and I'll tell you about that in a minute, or they're triaged out appropriately to their level of illness, because we have good support of urgent cares that are willing to see people that we need to be seen or screened. And of course, if they're appropriate to go to the ER and be screened, they should. If they're fairly asymptomatic or mildly sick, there's a lot of public testing and the CVS pharmacy testing out here. And so we actually have them set up, and it's pretty easy for them to go get a test. If the results audit are negative and they're still having minor issues that feel like they should be seen, we either set up a telehealth or a visit. But we're trying to do that balance, that sense of need that you need to provide service and be there for your community, your patients, but also avoiding unnecessary exposure bilaterally, meaning we don't want to expose them and they don't need to be exposing us. Services deferred during shelter in place was the next question, and how are you prioritizing them? We kind of resumed routine things with the lower risk patients, and we prioritized by looking at the old schedule, going back on who we canceled, and finding out who was really not really controlled in their blood pressure, not controlled with their issue, or had interrupted workups. They had an abnormal ultrasound, but it recommended a CT. You know, who was in the middle of things we can't drop. That's how we try to prioritize who we contact. And then I want to give 2 important reminders. Right now with pre-ops, there's a big push, if you haven't heard through other avenues, that when you do a preoperative visit, you need to do a social and supportive capability evaluation. You need to evaluate where the patient is able to transition directly to home from that type of surgery and avoid the SNF or rehab, because that could be the outpatient surgery center is a safe place, they're fit to go, but if they end up in a SNF, now they're in a high risk environment. And so that is one of the things we have in place on what we do. The others is seniors and high risk individuals. I got this through a town hall meeting with Optum the other day, which I think is a great idea. You need to make them make that their only visit to you. If they have to come in, it should be the first thing they do when they come in. And you ask them that whoever's driving them has to wear a mask. They should be from their home, masked and protected in any environment, all the way into the office. And their caregiver and driver themselves have to wear the mask through the transportation at all times. The reason is you don't want them going, okay, I got a ride, I'll go run all my errands, and then I'll drop in on the doctor. It's like, if you're coming here and you're high risk, let's just make that the only thing, or at least the first thing you do, so that you're not having that greater exposure. This is a long section. You guys mark me on time here, but the longer section is what have we done for our physical space and workflows? And a lot of you, this is common sense and you've done it, but we've done drastic changes. We did this rapidly in our lobby setup. We removed 80% of the chairs. Everything's 8 to 10 feet apart. There are very few chairs. There's one couch for families. And then we just limit the number of people in the lobby at any given time. When this started up, we were kind of lucky. We had very cool weather or even rainy weather. We just ran people back to their car and we call them back in. We get a contact number and we text or call them saying your room's ready. So they just stay out of the lobby and stay to themselves. We don't allow sick patients in the morning. We started that right away. Older people or well people or injured people could come in the morning. If you were any kind of an illness, we made it later in the afternoon for several reasons. One, we weren't going to commingle sick people with well people, and it gave the well people some comfort of knowing that, okay, this might be a safe place to be. The other reason is we can do the big scrub down at the end of the day and air out the room. We don't have to do it multiple times. We have to alter that sometimes because there are sick people that need to be seen right away, and we push them to the end of the morning so we can do the scrub down and let it air out at lunch. The other thing, this is very important, we moved all our strep screening, influenza screening, and COVID screening or swabbing, anything that had to do with an MA or somebody swabbing somebody, to a separate room. And I was lucky because my office I share with an orthopedist, and he had a room, a small room that used to be where his film processors were. And that room wasn't used anymore and the equipment was gone. So it had a separate door entrance. So we literally have a separate entrance door in a small room where one dedicated MA, only one of my employees does this ever. She fully dons the PPD N95, shields, gowns, everything. She goes in, preps the room. Those patients come into that room. We screen them there. And then she does the swabs there. And then she exits out backwards, disposing of the disposables. When we had our first patient that test positive, the county called us and asked us how we were doing it, because I was concerned, what do I do with my employees? They really thought that was an excellent setup. It actually has its own separate exhaust fan system as well. Not everybody has that ability, but if you do, you want to separate that away. No longer ever are we going to have an MA walk around with a swab that they did on a culture, then walk through the office and go to the little nurse lab area, which is behind them in that picture there, and have them do a screen. It's all done to one room. Matter of fact, when we see a patient in the exam room, we actually send them back out, and the girl gets ready and calls them in. If you're looking at her picture, it's this young lady to the left. She's been taking the big hit for us on exposure and doing everything. We don't allow, we used to be all hands on deck, everybody help everybody out, but now we work in paired teams to limit the number of people that are exposed to any one patient. The reason is our first COVID positive patient came in contact with probably 5 or 6 people. Somebody brought him back, somebody else did his strep and influenza screen, somebody else did this or that. He had the front check-in, the back check-in. He tested negative on those things, and he was very suspicious, and I was able to get him tested for COVID, and it didn't come back for a week, but suddenly a week later it was hard to find out who was he exposing, who was at risk. So now we limit the teams and the patients, and it's easy through the EMR to see who roomed the patient and those things, but we just kind of limited it the way that we were doing it before, which actually takes a little more time. And then We don't allow suspect patients in the office. We have a good urgent care and ER and public testing system now. I was never one of those, oh, you have a fever, you can't come here. I feel like I had to be there. That's why we were early set up to test, right? And then, but as time went on and public testing became available, we paired that out. There's mandatory staff and gloves, of course, the second they hit the office. All business people in our business office aren't allowed in the clinical areas after we see patients. And then we did mandatory online training for safety, PPD donning and disposal. Where can you go for that? Good resources at cdc.gov, county health, your insurance company training. And this one's gold, and people never remember this one, but your malpractice carrier has all kinds of resources. So we had everybody do mandatory what's safety and what's safe in the workplace in these times, and mandatory how do you mask and glove. And then of course we have the signage outside and provide it. We put up paper towels and Perel so people can open the door handles. In good weather, we leave the door open. We have touchless payments like you would at Burger King, and we try to limit all that time. Let me know if I'm over time on you, but I have a few more things. One of them is you limit exam room time. I don't have the study, but it was presented recently in the town hall that the outpatient physician office is a very low risk area if they're doing these precautions. But part of it is limiting yourself while wearing a mask in a room for about 15 minutes is how they cut that off. And so it makes us focus on staying on time more. Discourage family and others to be in the room at the same time. We also bought plexiglass counter screens. They're kind of elegant, nice looking. They sit on the counter and they have a little pass-through slot. And I was able to think about that and get those before plexiglass became an issue. So I was able to get those pretty early. And then every room is wiped down and aired out. What else? Oh, lunchtime. Can't use the break room like we did. We stagger lunches. Everybody has to be a good 10 feet apart. They have to spread out to have lunch. The last one was how did we address workforce fatigue, stress, fears? Well, I'm just a pleasure to work with. I'll have to say that, right? So that was one. I put it down the list, but I got to tell you, self-deprecating humor goes a long way. You know, make fun of yourself or let them make fun of you a little bit. Keep things a little bit on the light side is what we do. But the truth is, and we've done this on patient communication and doctors all the time, is a happy doctor or a confident doctor, a leading doctor, or is just a happy doctor leads to happy employees, leads to happy patients. You know, a pissed off, grumbling doomsday doctor leads to pissed off doomsday employees and then concerned and worried patients. So we keep it upbeat. When the schedule was lighter, we booked linear so that if we could end earlier, people, if they wanted to go to their families, could go home early. And those that wanted to stay on the clock and book their hours and not lose income were allowed to stay and do light activities. In the early days, we picked a local restaurant to support, and we would all get group lunch or cater in. And we still do that, or we just make the in and out run and get it for everybody. And it helps support local businesses, let them know we're there. And it helped out my employees not have to worry about their lunch and what they're doing. We always ask if they're comfortable with our efforts, and we're very supportive of their need to care for their family and any time off they needed. My wife in the early days of the toilet paper fiasco was at Costco and they had toilet paper. So she just brought a big bundle to the office, you know, just so people could just have some. An employee of mine that has an infant at home, she bought baby formula. So she didn't have to worry about getting a hold of baby formula, those sort of things. And then ask how they're doing and how their family's doing. And then one of the key things I was very upfront, when this thing started and they said 2 weeks, April, I told them epidemiologically, nobody looks at a virus shorter than 90 days or 3 months. So when this started in March, I go, look, this is gonna be a lockdown and they're gonna look at it in June, and then they're gonna be looking at it again in August. And I just told them, so the reality understood is we're gonna be like this moving forward. And so they just adjust and accept it, and it doesn't become an ongoing aggravation to anybody. I know I went through a lot of things, but that's the gist of those questions.
Thank you so much, Dr. Davis. I want to invite our attendees now to see if they want to chat on any questions for you, or also if you'd like to go off mute, you can go off mute, hit *6 if you happen to be on your phone line. Let's pause and see if anyone has a question.
I'll just add that currently, like Monday, we saw 52 people. Only one of mine was a telehealth and maybe 6 or 8 out of that were telehealths. And I'm shocked by that, because we push telehealth and we screen out and try to keep people out. We did hit a wall with people having ingrown toenails, you know, injuries they didn't intend to, things where they waited and waited and waited and finally came in. And so that is a lot of that. And so we think that'll level out, and we'll be doing more virtual care.
This is April with CQC. Thank you so much, Dr. Davis. And I want to say that this, the information you shared was so practical, and I'm just really blown away by how creative your response has been, especially just in the really practical considerations with your staff in your office. So I think it's just really helpful. So I have 2 questions, if that's okay. So one is, I'm wondering if you've just talked to any of your patients about, you know, the virtual visits, whether that's telephone or video or both, and you know, what their feelings are about that, if they're, especially those that maybe had always seen you in person, and if you've got any kind of positive or negative feedback on that. So that's one. And then my other question, just I think in the beginning you kind of were joking about, well, who are all these patients I was seeing? And I'm wondering if actually you've thought about that. Like, do you have any kind of guesses about, you know, whether it's all really just represents deferred care, people just putting off care, or do you have a sense that maybe there were some, you know, portion of office visits that actually didn't need to be in-person visits, or if you've actually given that, maybe that comment actually some thought, which I suspect you might have.
Yeah, no, we give it a lot of thought, and in reality, a lot of it is deferred care and routine care, and a lot of it is stuff that can move to telehealth that hadn't moved to telehealth. If a patient has a blood pressure cuff at home, we have a few labs on them, and we're going to refill their medicine, and we trust their machine. There's no reason we can't telehealth and go over the numbers with them and not have them sit in the lobby. A week before the shutdown, we were wall-to-wall, standing room only, with half the people wearing masks because that was our standard, you got a cough, flu season thing, and the other half just sitting there. And when I thought back after the shutdown, I was horrified over the fact we had 20 people, 15, 20 people in a room standing there with half of them sick. And so that's going to change forever. That's one of them. The other thing is, these things will stay the same, and virtual care, I think, should be woven into regular care. I gave talks last year on telehealth, and the pushback was it's not reimbursed, we don't know how to do it. And well, who's going to do it? I'm busy seeing patients. And now, since this hit, everybody kind of learned on their own. I, you know, really shocked that, you know, people went out and figured it out on their own, number one. And then number two, it's kind of just weaving into the schedule. We don't set aside Mondays, my PA only does telehealth. We literally are able to weave it in the schedule because we utilize everybody in the office to set up the visit. You know, the front, just like they would check somebody in, they make the initial call, they get the Zoom number or the DoxyMe waiting room set up for the patient. You know, the MA steps in, and we just walk through it stepwise, so it's worked out. The question to those that don't have smartphones or access the telehealth, it's really funny because I'm starting an initiative and a volunteer thing down in South LA, because the most needy people are those that could use some virtual care, don't have the abilities. For us, to answer your question, is they allowed telephone voice to voice. And I had only a few patients with an old flip phone and refused to get on a computer because they think they're evil or something, right? So we were able to do some by phone only, but that's a limitation. And so we work really hard, and half the time it was, particularly with the elderly, it was a relative, a daughter, a grandson, or somebody who stepped in with a computer or a smartphone and loaded up the Zoom and showed them how to do it. That's how we deal with it. If you can't, you can't, you can't. And everybody else get creative or help them out.
Thanks, Dr. Davis, and thanks for chiming in with those questions, April and Michelle. So at this point, I'd like to thank Dr. Davis again for sharing his practical tips and experience. And now we're going to open it up and have some sharing among all the attendees on the line. So Jose, if you wouldn't mind going to the next slide. So we'd like to encourage everyone to now join in for our next poll. And this is kind of referencing to something that Dr. Davis spoke to, which is thinking about your current total visit volume today. This includes both face-to-face and telehealth. What is it compared to a pre-COVID-19 visit volume? Is it 80 to 100%, 60 to 80%, 40 to 60%, or less than 40%? I think, Dr. Davis, you might have said that yours is already up to 90, if I was
mine is surprising. It's 80 to 90% every day. And I think it's just the rubber band effect. I fully expect it to actually slow down a little bit. It's the rubber band effect of put off things and nervous people who want their health attended to versus the nervous people that aren't taking care of themselves. I seem to be lucky that way.
Right, yeah. So I encourage the rest of you to select your answer and make sure you hit the submit answer button. We'll give a few more seconds. All right, so the results is that most of the 50% of those on the line are actually back in the 40 to 60% range, with a mix to 60 to 80 to 80 or 100. So yeah, it looks like you're in the top tier there, Dr. Davis. So the next question then that we'd like to have everyone chat in is that we know that in-person visits are still down. What are you hearing from patients about the reasons why they are not wanting face-to-face visits? So please feel free to chat that in, or if you would like to open up your lines and share that way, that would be great too.
While we're waiting, I'll just remind it, for me, it's all over the board. People that are scared to death. And I tell them, we're not a COVID dispensary center. We're a COVID prevention center, right? And recent studies have held up that outpatient facilities can be low risk. And all the way to people I can't keep out. I have some people that's a social center, and I literally have had told them, do not come back for this follow-up. So it's all over the board.
Yeah, I think you and I were mentioning before the call that they now say that outpatient centers are just as safe as grocery stores. So,
well, you know what? The thing I saw, and it was a town hall and a graphic, so I don't have an article to go with it. It was way below. We were just barely a notch above staying home and away from everybody. Grocery store was in the mid-range of risk. And it really is based on following these guidelines and limiting the amount of time you're in a room with somebody. Which is a pressure to keep on time, which is always a clinical operational problem. So as your volume picks up, your ability to start on time, stay on time, to minimize your waiting room and waiting crowd, and to minimize your exposures.
Yeah, it's operational ballet, it sounds like. So we have a couple responses through the chat. Some family members sharing that they're scared of getting the virus. Father who's discovered the joy of virtual visits and prefers it. Another participant, Michelle, shares that it's more convenient to have telehealth, that's scared of catching COVID. The doctor's not offering in-person visits yet. And then Charlene offers that patients might be afraid of getting sick and not wanting to potentially expose themselves to COVID, especially for those with chronic conditions. So let's go ahead. Thank you so much for those perspectives. I think that those kind of show the range that Dr. Davis, you were sharing as well. I'd like to go to the next question before we go to the other question posed in the chat. This was, so next slide, Jose. This was a theme that came up in several of the registrants' questions as attendees were inputting their challenges with reopening. And the question is, how does your organization determine which patients get a face-to-face visit versus a telehealth visit? Is there sort of a formal process like risk stratification, a risk algorithm, or some sort of operational workflow that, I think Dr. Davis gave an example of that as well. So we'd love to sort of pause, get folks to chime in either in the chat or on the telephone lines. So looks like one practice said not applicable for her organization. So I think in previous webinars, we had heard some mentions of like a risk stratification protocol, and it sounds like Dr. Davis, your practice has adopted a workflow to gauge which patients should go where.
Yeah, and we use the practical sense of age and underlying conditions.
Mm-hmm.
Some of the tragedies of this were like a newly diagnosed aggressive breast cancer in a young woman who was supposed to start chemotherapy the week they did the shutdown. You know, there's some real stories of, you got to think hard. What are we going to do about this? What are we going to delay? What are we going to do? And those were the ones that, were easy to work on early. It's the middle ground stuff, that you almost have to just have a standard protocol, try to push the telehealth when appropriate,
Mm-hmm.
And then flip the coin and do your best to make it safe for everyone.
Right, build in some flexibility.
Yeah.
Jason shared provider triages with clinical judgment given known risk factors. So kind of that
one of the
mm-hmm.
One of the benefits of a small practice and being in the same place 30 years, most of the staff, a lot of the staff and all the clinicians have an understanding of individuals and their health issues. So it's a little easier for us to triage or balance things out just because of the long-standing
mm-hmm.
knowledge of individuals. It's a little harder in a bigger clinic setting when the people on the phone don't know. You need to have more of a cookie cutter triage system.
Mm-hmm. Yeah, that deep knowledge must be a huge asset. So I'd like to go back then to a question that was shared in the chat from Amy Anderson. And Michael, if you wouldn't mind perhaps copy pasting it, but the question was, are you considering identifying specific cohorts of patients for whom telehealth and virtual engagement might be a long-term option? Also, are there opportunities to enhance proactive information and self-care resources that can be delivered through telehealth mechanisms?
If you want me to answer or everybody to answer,
yeah, please.
It's a great question, and I think that is the future of it. If our friends are here from Kaiser, of course, they're set up more than anybody to move their new norm to being telehealth. They have others care more, and other models have the ability. You talked about the program at Sutter, where that can become the standard of some care, and that will move towards that. And I'm hoping more and more will move to that. The cohort, I would say, is going to be the seniors, Medi and Medi-Cal, the people that'll pay to do it, the people where they're higher risk and it's a high yield to keep in contact with them. It would be that. When I was giving talks on telehealth last summer, some of the advisory group studies and things showed people want to do telehealth. And the demographic is really the 30 to 45-year-old female, somebody balancing kids and stuff. That was the biggest group that wants to do telehealth, but they want to do it with their doctor. They didn't mind calling teledocs, but they kind of wish they could with their doc. And this crisis has brought it out that I think that's going to be more and more capable of doing. I think it's a good thing.
Yeah. So I'd love to hear from others thinking about how your organization might be identifying cohorts, planning for the future. Well, it sounds like from what we've been discussing today, there's definitely an opportunity to sort of consider that as a in future planning, and definitely, Amy, to your point, create some resources and information that patients can access. So we have a few more questions that we wanted to poll attendees on. So Jose, if you wouldn't mind launching I think this is our second to last poll. For those that have opened up and are seeing in-person patients now for in-person visits, what are you generally observing when patients come in? Is there a misdiagnosis, a deterioration in chronic condition, increased mental health needs? And if there's another observation, feel free to chat that in.
Make sure to select your answer and click the submit button.
Okay, I'm seeing a couple answers coming in. Thanks, Dr. Davis. Delayed diagnosis. So the key results have been increased mental health needs, and that is unfortunately no surprise, as we've heard that both the delayed care, perhaps poor perceived access, and of course the stresses of living in a pandemic have contributed there. So thank you for sharing on that tack. So our final sharing opportunity we wanted to pose to all the attendees is on our next slide, and thinking about kind of to what Dr. Davis was sharing about ways that you are motivating and supporting your staff, providers, and care teams, given that they've contributed so much in the past few months and are still being asked to rise to the challenge today. Are there ways that you and your organization's leadership have been motivating and supporting them? Please feel free to chat those in or open up your line. I personally would vote for in and out, but. Thanks, Dr. Davis. Good idea here. He's going to make small plaques made and have a COVID 2020 or Heroes event. That is a wonderful idea, and I hope others can spread it to their orgs if they haven't already considered such a thank you. All right, well, I think I'm going to wrap up then. Thank you everyone for tuning in, and especially to Dr. Davis for sharing his practice's experience, observations, and some advice for everyone on the line. Oh, thank you. We have one response to the staff motivation. We're having weekly Zoom check-in meetings that staff can join to get updates from the management team and share any concerns. So yes, just regular communication is probably very important, especially as everything is changing. Thanks, Charlene. So thank you again to Dr. Davis for joining us and sharing. Really appreciate hearing your specific examples and advice. I'm going to continue wrapping up, so if you wouldn't mind going to the next slide, Jose. If you joined late or if you haven't yet, I will encourage everyone to take our CQC's brief survey that influences the direction of our next Quality Improvement Learning Collaborative CalHive. So the link should be in the chat, and please go ahead and take that anytime by the end of the week. We very much appreciate your participation. The next and our final poll is how this webinar met your needs. So would very much appreciate you taking this very brief and final poll. Finally, our last slide is ways for you to stay connected. I encourage you all to join us next week for our Accelerating Integrated Care Aligned Payment webinar, and check out our CQC COVID-19 resource page, and feel free to send us an email at this address if you have suggestions for a webinar or just want to join our mailing list for future announcements. Thank you all. Thanks to Dr. Davis, and hope you have a lovely rest of your afternoon, and take care.